Hi, continuation of your anatomy and physiology on the musculoskeletal system. So the next part that we'll be talking about are your joints. So when I talk about joints, it's the space where two or more bone would come together. They hold the bone together, and the main purpose is to allow movement. So major functions to provide movement, and obviously to ensure the flexibility of our body. There are several kinds of joints. So let's try to recall this. Synarthrosis is one. So they are fibrous joints. They are immovable. So earlier I mentioned that joints are between two bones. So a good example of your synarthrosis or your fibrous joints are the joints found in our skull. So recall that our skull would have several bones. So this is your frontal bone and this will be your parietal bone here. Okay, so if you would look at it, it's joined by the coronal suture. And your coronal suture is actually a synarthrosis. The next one is your amphiarthrosis. So in your amphiarthrosis, these are cartilaginous joints. They would allow for limited motion. An example of which is our vertebra, our spine, and then you have your symphysis pubis. So you might be wondering how come the symphysis pubis will be moving. So the movement of your symphysis pubis will be particular on your pregnancy or your delivery. Then you have your diarthrosis. Diarthrosis or your synovial joints. So when I say synovium, it would be containing fluids. So these are the freely movable joints. A good example of which will be your elbow and knee. Because they are highly movable, they are also at high risk for injury. So types of movement again, according to structure. So if you would look at it, the previous slide would equate the two. And just to recall, your fibrous joint would permit little or no movement. An example of which is your skull joints. Then you have your cartilaginous joints, which would contain hyaline cartilage that would fuse together, articulating bone ends. Then you have your synovial joint, which is enclosed by a cavity-filled synovial fluid. So they are again freely movable. Your synovial joints are described based on their anatomic structures. So again, when I talk about synovial fluid or synovial joints, they would be enclosed by a cavity filled with your synovial fluid. So your synovial fluid would act as a lubricant to allow movement, okay, free movement. First one is your ball and socket joint. So it's a type of synovial joint which permit full freedom of movement, allows flexion, extension, hyperflexion, hyperextension, and even your rotation. Good example of which is your shoulder, and then you also have your hip joint. Then you have your gliding joints. Your gliding joints would allow for limited movement. An example of which is your wrist joint. The gliding movement of the wrist is characteristic of your biaxial joint. Then you also have your hinge joint. Your hinge joint would allow movement in one direction. An example of which is your elbow and knee. So your hinge joint would allow motion in one plane. Basically, it's flexion and extension. So the knee is often classified as a hinge joint, but it is also capable of rotating slightly, as well as it can flex and extend. Specifically talking, your knee is considered as a condylar type of synovial joint. Then you have your pivot joint. So your pivot joints would move around a central axis. It would permit rotation only as in the radio-ulnar area. They move around the central axis, and that would be without displacement. Again, an example would be your radius and ulna. Then you also have your saddle joints. The saddle joints are two planes at right angles to each other. So an example of which is your thumb. Now, there are several types of muscles in our muscular system. So it's summarized on this table. So you have your skeletal muscle, perhaps the most humorous of the muscles. It's considered to be striated, and then a function of which is voluntary. So an example of which is your bicep, triceps, your deltoid, and your gluteus maximus. Then you have your smooth muscles. Your smooth muscles are non-striated. It's involuntary. An example of which is your bladder and then your stomach walls. Then you also have your cardiac muscle. Your cardiac muscle is striated Okay, and then its control is involuntary. Of course, cardiac, so an example of which will be your heart. Okay, so take note that among the types of muscles, the only one that is considered to be voluntary is your skeletal muscle. And again, note there are two striated and there are two involuntary types here. So familiarize those to differentiate these different types of muscles. Now, your skeletal muscle is attached by tendon to the bone. Earlier I mentioned MTB, so muscle, tendon, bone. It will attach to connective tissue and other muscles, soft tissue, or skin. When I mentioned the term fasciculi, that would refer to parallel groups of muscle cells, whereas your fascia or your epimysium, okay, would be your fibrous tissue enclosure. The more the fasciculi, the more precise the movement of the muscle would be. So the main function again of your skeletal muscle would be no other than movement. And any impairment on your physical or in your skeletal muscle functioning would obviously lead to disability, or again the nursing diagnosis, impaired physical mobility. The supporting structures, tendons. So tendons, as I've mentioned, will attach muscle to bones. So these are made of tough fibrous tissues. For the ligaments, kindly correct my previous entry on the previous recorded topic or lecture. Again, a correction. The ligaments would attach bone to other bones at joints. I think on the previous lecture I mentioned that the ligaments would attach muscle to muscle. So kindly correct that. The ligaments would attach bone to bone or other joints. Then, so these are your supporting structures. Another supporting structure will be your bursae or your bursa. So your bursa are small sacs with synovial membranes located at the joints and bony prominences. And then you also have your cartilages, which would surround the articulating bone. So usually, these can be found in the joints of the shoulder, elbow, and the knees. The purpose is to prevent friction, I'm referring to the bursa here, between bone and the structures adjacent to the bone. So your bursa is the one which is filled with your synovial membranes. Again, the purpose is to prevent friction between the bone and the structures adjacent to your bone. Now, the meniscus. Your meniscus is a piece of fibrocartilage found where the two bones would meet. Okay, so it's found on the joint space. The purpose is to protect and cushion the joint surface and bone ends. So it's a crescent-shaped menisci are positioned between the ends of the upper femur and the lower tibia. So again, a crescent-shaped menisci, or your meniscus plural, are positioned between the ends of the upper femur and then the lower tibia. Now, muscle tone. So if you would look at how skeletal muscle contraction occurs, recall that your muscle cell would contract in response to nerve stimulation. And of course, that would be in response to your efferent stimuli. Okay? So the contraction of the muscle fiber can either result to isotonic or isometric contractions of the muscle. The speed of muscle contraction is variable. So your red muscles would increase, with the increased amount of myoglobin, would contract slowly and powerfully. Whereas your white muscles, which contains little myoglobin, would contract more quickly. Okay, to that, you have your muscle tones. So one is your tonus. So your muscle tone or tonus. So it is produced by the maintenance of some of the muscle fibers in a contracted state. It is minimal during sleep and increases when the person is anxious. So one, flaccidity. When I say flaccidity, it's limp, okay, without tone. Usually, this results from lower motor neuron lesions produce decreased tone. Then you also have your muscular dystrophy. So dystrophy meaning there is a decrease in the size. And then you have denervated muscles. When I say denervated muscles, meaning there's a lack of nerve innervation to those muscles, resulting to soft and flabby, and then later on atrophies. Then we have your spastic. So when we say spasticity, the muscle is with greater than normal tone. Recalling our anatomy and physiology in neuro, upper motor lesion would usually lead to spasticity. It would increase the muscle tone. Cerebral palsy is also one cause of spasticity. And then the muscle becomes hypertonic and the reflexes become hyperactive. Then you have the term exercise, disuse, and repair. So to maintain function, your muscles need exercise. Exercise would increase the muscle size. The resulting term for that is hypertrophy. Atrophy, on the other hand, is the decrease in size of a muscle, which is related to age and disuse. Now, bed rest and immobility can cause loss of muscle mass. So add that to your previous knowledge. Earlier, I mentioned that when you have immobility, it would also decrease the density of your bones because your immobility increases the activity of your osteoclast. And now, we should know that bed rest and immobility would also result to loss of muscle mass. So if you can notice, there are patients, for example, who are staying in the hospital for long, such as that a stroke patient. The tendency is that there will be a decrease in the size of their lower extremities, and that is related to your atrophy of muscles. Now, let's proceed to the assessment of your clients with disturbances in locomotion. So, for the personal health history, you need to ask about sports and traumatic injuries. So, if your patient would have sports and traumatic injuries, you need to ask about the NOI, POI, DOI, and TOI. NOI, POI, DOI, and TOI. And the nature of injury. P, place, the date of injury, and then the time of injury. Okay, these are the things that we're asking, especially if our patient had a vehicular accident. Okay, so nature of injury could be fall, vehicular accident. Okay, so your health history should be detailed and accurate because that will help us predict the degree of damage that your patient would have. Then you need to ask for previous hospitalizations, illnesses, and complications. Furthermore, you need to know the activities of daily living of your patient and their ability to perform such. Also, find out if what are the assistive and adaptive devices that your patient are using. Next, you need to find out the current lifestyle. Okay? Now, you need to find out if your patient is performing weight-bearing activities. If your patient is not doing weight-bearing activities, you would expect that there is a decrease in bone mass and there is also a decrease in muscle mass. Ask about high-impact sports. Also ask about the use of tobacco. So the use of tobacco is obviously harmful to our bones. Then excessive alcohol intake. Excessive alcohol intake would also increase the osteoclastic activity in our bone. Other than that, you need to know the occupation and work life of your patient. Okay, there are occupation, for example, if they are exposed to construction sites, their tendency is that they will be at higher risk for fall and accident. So for that reason, you need to monitor if they are wearing the proper PPE, personal protective equipment, when they are in the construction site. For the allergies, you might need to know if they're allergic to dairy products. Okay, your dairy products would be very rich in calcium and vitamin D. And then the current use of drugs. So there are illicit drugs, there are over-the-counter drugs, and there are maintenance medications that could possibly result to bone damage. A good example of your maintenance medication will be your steroids for your asthma. Your steroids is known to decrease the bone mass. It would decrease the bone mass. Okay? Other than the previously mentioned, you need also to ask for the nutrition history of the patient. You need to determine if there is inadequate nutrient intake. Of course, we'll be worried about calcium. So take into consideration patients with lactose intolerance. Take consideration, for example, patients who are having Crohn's disease or ulcerative colitis, irritable bowel syndrome, and your patient who had colectomy. Okay, these patients would have decreased absorption of calcium. Then family history and genetic risk. So identify disorders that would have probability to damage your bones. And then the current health problems experienced by your patient. Next, you need to consider one of the common symptoms, which is pain. So if your patient is complaining of pain, of course, you need to do your cold spa assessment. Character, onset, location, duration, severity, precipitating, aggravating factors, and alleviating factors. So the bone pain is usually described as dull, deep ache, boring, not related to movement, and interfere with sleep. On the other hand, your muscular pain would be described as soreness or aching, muscle cramps usually, as they would say. Your fracture pain, on the other hand, is sharp and piercing. It is relieved by immobilization. Whereas your joint pain which is around or in the joint and would typically worsen with movement. So joint pain is associated with movement. Another common symptom is altered sensation. So once your patient would have paresthesia, okay, so paresthesia is sensation of burning, tingling, or numbness. Then your patient may also complain of altered sensation because of the pressure on nerves or by circulatory impairment. So in other words, for example, if there's swelling of the muscle in conditions like that of your cellulitis, the nerves are being compressed. Okay, or if the blood flow is decreased going toward the nerve, so you will have your altered sensation also. Then, soft tissue swelling or direct trauma to these structures can impair their function. Next, weakness. If your patient is having weakness, you need to determine whether it is involving individual muscles or muscle groups, and whether this is proximal weakness or distal weakness. Proximal weakness may indicate myopathy. So when I say myopathy, it's a problem in the muscle tissue. Whereas distal weakness may indicate neuropathy. Neuropathy is a problem in your nerve tissue. So myo, okay, muscle, neuropathy, your nerve tissue. Now, another crucial assessment is your neurovascular status assessment. So when we are doing your neurovascular status assessment, we'll be checking again for altered sensation, an example of which is your paresthesia. Then you also have your neurovascular status assessment. So in neurovascular status assessment, you have your CMS. Okay, so CMS, circulation, motion, and sensation. Under circulation, we would want to check the color for paleness, cyanosis, or mottling. If the temperature will be cool, and then if the capillary refill will be more than 3 seconds. These are all indications that there is already a decrease of blood flow going towards the peripheral area. Then you have your motors. So for the motors or motion, you need to check for weakness or paralysis. And then for the sensation, you need to check for paresthesia, unrelenting pain, pain on passive stretch, or absence of feeling. So if you would look at this, your neurovascular status assessment is actually the reason why we leave, for example, one of the fingernails, or for example, why we big the big toe, or why do we leave the fingers open when our patients are casted. So when I say casted, recall that a cement-like substance that is used to immobilize your extremities whenever fracture would occur. So if you can notice, among these patients, they would usually leave, the doctor or the orthopedic surgeon would usually leave the fingers open or visible. So the purpose of that is for your neurovascular status assessment. Okay, so you have your 5 Ps. The 5 Ps are pain, paresthesia, paresis, pallor, and pulselessness. These are your danger signs. Okay, so these are your danger signs. So if ever this occurs, you would suspect that your patient may be having cellulitis, or you may be already having neurovascular compromise. Okay, there are other literatures that would talk about 6 Ps. Okay, if interested, try to find out what is the 6th P not included in the list here on the left. Okay, it pertains to temperature. Then on assessment, of course, we'll be doing the bones, joint, and muscle assessment. Okay, you need to do the cephalocaudal approach, of course. Then inspection and palpation are the primary techniques. You need to include the range of motion, and then you will have your muscle strength assessment. In muscle strength assessment, we are using the scale of 1 to 5 to perform the assessment. Now, on inspection, if we are inspecting our patient, you need to check for posture. You need to check for gait. You also need to check for mobility, gross deformity, and even impairment. And then, if needed, you need referral to physical therapist. Your physical therapist or occupational therapist would be able to coordinate on the rehabilitation program that is intended for our patient. Okay? So, on posture, normally, your posture would include the person's body build and alignment when they are standing and walking. So most of the patient with musculoskeletal problem would eventually have a problem on their gait or way of walking. So when I talk about gait, it's the way of walking. But going back to posture first, so when we are assessing the posture of the patient, okay, we are assessing the stand of the patient. Normally, the spine would appear to be convex at the thoracic area and would appear to be concave on the cervical and lumbar area. The three abnormalities are as listed on the slide. So you have your kyphosis, lordosis, and scoliosis. So kyphosis, there is forward curvature of the thoracic spine, bowing or rounding of the back. So commonly we refer to it as your hunchback or slouching posture. Then you have your lordosis. So lordosis is sway back. It is an exaggerated curvature of the lumbar spine. Oftentimes, they would say that your lordosis is the pride of pregnancy. Okay, so imagine how they would look like. And then you have your scoliosis. Scoliosis is the lateral curving deviation of your spine. So best to assess scoliosis if you are standing at the back of the patient and then your patient would be leaning forward. So that will be your scoliosis. So gait assessment. For the gait assessment, but before that, first, okay, these are the images, by the way, of your kyphosis, lordosis, and then your scoliosis. So the letter S curvature and the overarching of the upper part of your spine here for kyphosis. And then for your lordosis, the excessive curvature of your lumbar spine. Common causes. Let's add a common causes. So kyphosis. So your kyphosis are usually related to degenerative diseases of the spine. An example of which will be your arthritis and disc degeneration. They may be related also to fracture related to osteoporosis, injury, or trauma. And then you have your lordosis. So your lordosis may be brought about by tight low back muscles, excessive visceral fat, and even your pregnancy. Then you have your scoliosis. Scolio may be congenital, present at birth, idiopathic, without an identifiable cause, or the result of the damage to the paraspinal muscles, oftentimes a result of your muscular dystrophy. Then, gait. So I've been talking about gait. So when I talk about gait, this would refer to your way of walking. A very good assessment would be to ask the client to walk around the room. Another assessment possibility is for you to ask the client to walk away from you and going towards you. Now, gait, so you need to watch out for a limping motion. A limping motion would indicate that your patient is having painful weight bearing, meaning by the time that the foot would set foot on the ground, the patient would feel there is some pain. And then it could be caused by one extremity being shorter. So the shortening of one extremity may be a sign of fracture, or it may also be a sign of a condition that we refer to as avascular necrosis. So when I say avascular necrosis, there is absence of blood supply going towards that area, leading to necrosis, the death of our bone tissue. Other problems. So you have your spastic hemiparesis gait, which is classic for stroke. You have your steepage gait, which is classic for lower motor neuron disease. And then you also have your shuffling gait, which is classic for Parkinson's disease. If you would look at these videos, so this video are demonstrating one of the gaits that I have mentioned. This is actually videos. These are videos retrieved also from the net. Okay,
There are
so
small steps.
try to find out
Oftentimes there's a tremor
which of the
associated with
following
this.
is your
And as the
steepage,
gait progresses, there may be a
which of the
picking up
following
of
is your
speed, or
Parkinson's
what's
gait or
called a
your shuffling
fenestrated
gait.
gait. And then in turning, instead of having the normal turning,
Phases of gait. So there are two phases for gait. One is your stance, and then the other one is your swing. So when I talk about the gait cycle, it would be a sequence of events or movement during the locomotion in which one of the foot would contact the ground to when the same foot contacts the ground and involve the propulsion of the center of gravity of the body. So when we are walking, we are actually transferring the center of gravity of our body. So it would be recorded from the time one foot strikes the ground until that episode recurs and starts the next time, which would repeat the cycle. Okay, so stance. When I talk about stance, it is the time wherein the foot remains in contact with the ground. Okay, the foot remains in contact with the ground, composing about 60% of the cycle. Then you have your swing, wherein the part of the cycle during which the reference foot would not be in contact with the ground and swings in the air. Okay, so try to observe somebody who is walking and then try to observe when is the stance and then when is the swing part. So your swing is the motion part. Okay, it's the movement part and would constitute about 40% of the cycle. There are two kinds of problems that now there are two gait abnormalities that we need to watch out for. One is your antalgic gait. So antalgic, that's a problem in your stance phase. There is a problem on the time that the foot would remain in contact with the ground. And this is often the result by pain. Okay, look at the name, antalgic. So algia will be pain. So this is against pain. Meaning, by the time that the patient would set foot on the ground, the foot would set on the ground, your patient would feel pain. So the tendency is for them not to fully place the weight on the ground on the affected side. Then you have your lurch gait. The lurch gait is an abnormality in the swing phase. This occurs when the muscles in the buttocks are too weak to allow the person to change weight from one foot to the other. So too much weakness. They oftentimes refer to the lurching gait as a compensatory gait. Okay, so it is referred to as compensatory bending, okay, or lurching to the side of pathology to balance the center of gravity of the body. Okay, on the succeeding topic, we'll be talking about the application of your inspection, and then that would include some assessment on your joints, and then some special assessment and your diagnostic test. Thank you for your attention.